All righty. It's 7 o'clock. Time for us to start our session. I want to welcome our guests. Tonight, we have two guests joining us to talk about OCD and their experiences and share some thoughts and answer some questions. So I'm going to start off and give them an opportunity to introduce themselves. First person that I want to come to is Ross Tomsic. Ross, you want to introduce yourself?
Sure. Yeah, I'm an IT guy who's had OCD pretty much his entire life, figured it out around 4 years old. Never a great story, is it? But yeah, mine's been related to death and dying, and presumably whatever happens after that, or lack thereof. And so I had that realization at 4 years old, and it's pretty much been with me ever since. I've been through all kinds of treatments, a lot of talk therapy. Doesn't actually help OCD all that much. And then I've personally been treatment resistant, so that makes it even more fun. I have been on medication for it after I got my original diagnosis, I want to say 6 years ago. And I've, again, been through pretty much all of them at this point. I'm currently waiting on a gene test, actually, to come in the mail to dive deeper into that and see what might help me out. Obviously, this definitely impacts my professional life, but I've gotten quite good at I don't want to say coping, but keeping it together. Especially, I'm married. My wife, has been instrumental in improving my my diagnosis, my prognosis. She actually got me the diagnosis, or the doctor who was responsible for it. But yeah, I work in IT, so there's a lot of stress. There's a lot of interpersonal relationships that I wasn't really wanting to have when I first got into it. I realized early on that it's very client focused. It's very dealing with people. So at first I thought I might even be autistic, but I had several professionals who came and talked to me, and they said, you do not qualify as at least as what we see as autistic. You're way too good with people. You're way too good talking to people. And I'm like, well, great. So what do I have? And then years and years later, I've gotten better at it. I have a very bad TikTok where I'm trying to share my experiences and hopefully raise awareness and elevate that. And I'm going to be branching out into YouTube, hopefully. Just trying to get past the 100 terrible videos, so to speak. And so that's pretty much me in a nutshell right now. I'm sure we'll get into more later.
Yeah, great. Yeah, we definitely have a lot to follow up with you on that. But before we get into that, let's move to Donna Lewis. Donna, can you introduce yourself and tell us a little bit about yourself?
Sure. Hi, I'm Donna. I am an attorney here in Washington, D.C. I work on matters for the federal government. Those are civil rights matters and matters related to disability. And I'll just leave it at that. I support causes related to mental health and disability and patient advocacy. And I also write and draw the cartoon and comic strip Reply All and Reply All Light. Those are syndicated by the Washington Post Writers Group. And you can see my work at dailyd.com. And that's about me. About my OCD, I had been diagnosed for decades as depressed. And there were a lot of periods, obviously, where I was depressed, but I always felt that depression was not my problem because treatment for depression just didn't do anything for me. It just didn't help the problem. because I was obsessed with thoughts of death and thoughts of doing dangerous things and thoughts of having dangerous things happen to me. And I didn't start finding out about how that can be OCD until about 7 years ago, when I was finally diagnosed as having mixed obsessional thoughts by my current psychiatrist. And as soon as I got the diagnosis of mixed obsessional thoughts, I was able to get on a medication that was like the difference of night and day. All of a sudden, my brain was working, and it was just clear as day that my problem was obsessive thoughts. And I do have to say that I was extremely angry for a long time, because it was very obvious that if I had been on that medication maybe decades earlier, I could have had a different kind of life. So I'll just put that out there for anybody who's in a similar situation. But I'm past that now. So 7 years ago, I was diagnosed with mixed obsessional thoughts, and I started on a medication that made all the difference for me. And then the best news is that last October, I started TMS. And the TMS that I started was with the H1 coil, which is for depression. And I had amazing results with the H1 coil. And I just found out literally yesterday that I'm approved for the H7 coil, which is the OCD coil, and I start that on Monday. So I've gone from I wasn't planning to be here now to I'm extremely hopeful. I haven't had obsessive thoughts about dangerous things now for longer than a month. And it's just the longest period that I've ever gone without that in my life. So I am thrilled to be here.
That's fantastic, and we appreciate you both being here. It's interesting that both of you are dealing with either treatment resistant or at least a rough beginning until you got into treatment. And before I start getting into some more questions and follow-up here, I just want to share, I didn't even share my name yet. I'm Andrew Kolsky, and I'm a licensed professional counselor. I work primarily with OCD and anxiety disorders. And so for any of the audience members who signed up at stopmyocd.com, that's where you can find me. And I try and post a lot of information that's helpful to people. We run a free support group there. And also you can find links to a lot of YouTube videos that I put out that are educational and hopefully helpful to people with OCD. So with that, let me start off and jump back to Ross for a minute. And Ross, I find it interesting that, it's normally a small number of people that fall into the treatment resistant category. And when you do fall into that category, it becomes a real challenge to try different types of things, from therapy to medication to TMS and other things. So can you share with us a little bit more about specifically what have you tried and what type of results did you get from each of those things?
Sure. Like I mentioned before, talk therapy was definitely a big one. Like our other guests, I was repeatedly misdiagnosed, or at least partially diagnosed, because it was partially accurate, right? With generalized anxiety and depression, and God knows what else. Definitely glad we're past the WebMD phase, because you can assume you have pretty much anything. But having said that, I don't remember a lot of the medications from back during that period, but I've more recently done fluoxetine and buspirone, and those are the big two that I remember. I'm currently on, I can never remember these names, clomipramine.
Clomipramine.
Clomipramine. Okay. Yeah. I look at the first 6 letters and make sure that they match, which is kind of funny because I did go into biochem, but went a different way, obviously. So recently, what is it? About a year ago, something like that, I signed up for an OCD, and that actually, the therapy there, the ERP, and the community as well, is something that sort of inspired me to go on this path and find more awareness and find a way to reach out and help people, or at least share my experience if that counts as helping with people. But the ERP is probably the most impactful treatment that's worked for me. I haven't tried the what was it called, the coils, or haven't even heard of those, so that might be next after the genetic test. But really, I don't fully understand the resistance myself. I'm pretty drug resistant overall. There's a lot of medications that barely affect me. So that might have something to do with it, but it's really the ERP, and I've hopping from a couple of medications, a couple of SSRIs specifically, from one to the next. And then once the side effects get too bad, I move on to something else. And I've been through, on my 3rd psychiatrist from second psychiatrist from an app called BetterHelp, which is a local psychiatry place around me. And they've been quite good from my experience. But again, finding that right drug is just torture.
Yeah. You know, one of the things that also I recognize that each of you said was about sort of the initial diagnosis and what you went through. And one of the things that I tend to see a lot, and of course I'm tuned into it now because I focus on OCD, but I wasn't aware of it before, is that when you talk to counselors, when they go through their training, they really, in almost every case that I've spoken to, don't get any training in school about OCD. And if they do get any training, it's just sort of a mention that there's something called OCD, and that's about it. And it's the same for psychiatrists and medical doctors. And so a lot of times I will talk with patients who say, well, I saw a psychiatrist and they, either thought that I had anxiety or depression, like Donna says, and they didn't know what type of medication to prescribe, or they prescribed something, but it was the wrong one or the wrong dose because they didn't diagnose the OCD. And that's been a big issue that I hear a lot of OCD practitioners talk about, is that they have clients who come to them who were misdiagnosed and therefore never got the treatment that they really needed. So I know there's a push on to try and get more education out there for providers so that they can recognize when they're dealing with OCD. And one other point about another thing that you said, Ross, which was, is it autism? Well, there's a lot of things about someone who might be on the autism spectrum that may look like OCD, but isn't OCD. And then there's sometimes where the person might have both things going on. So it can get quite complicated from a diagnosis perspective. And you really need to have someone who really fully understands the differences to be able to figure out what's what. So, so Donna, based on all of that, can you enlighten us a little bit more about your experience from that perspective? As a patient, how did you feel and how did you react to that?
I think that what I'm learning the most is that the language is not the same across different disciplines. So starting back when I was in college, when I started presenting to like the counseling centers, the crisis centers at college, the only thing that I knew how to say was that I wanted to kill myself. I didn't know other language for that. All I knew was that I had these thoughts for me, it was a voice in my head. But what happens is when you present as having a voice in your head, the treatment teams have to make a determination as to whether or not you're psychotic. Because if you're psychotic, one whole set of things happen. If you're not psychotic, a whole other set of things happen. And I was not psychotic. And so I was automatically determined to be depressed or depressed with anxiety, generalized anxiety disorder. But the generalized anxiety disorder was never highlighted or anything like that. So I was always characterized as major depressive disorder with suicidal fill in the blank. It could have been, there's a million categories of suicidal thinking. And the problem with that is that nobody ever addresses the fundamental, the foundation of the suicidal thinking. And what the suicidal thinking is intrusive thoughts. There are these repeating intrusive thoughts, these obsessive intrusive thoughts of danger, and different people have it differently. I'm sure that Ross and I could probably talk about it for 10 hours straight and feel like we had just gotten started. I can see Ross already, like me and Ross, like we could talk about it all night because it doesn't trigger us. It gets it out. Like,
Yeah.
I would love to talk to somebody about my imagery and all that because it helps me to get it out. But like my family is scared to death to ever talk about what might be in my mind because they're scared they'll trigger me. I'm already way too triggered for my family. But the question to me was always, do you have a plan? Are you going to do something tonight? Are you a risk to yourself? Are you a risk to other people? That's not what I needed help with. What I needed help with was the obsessive intrusive thoughts. Those were never medicated. When I was finally medicated 7 years ago for those obsessional thoughts, I started experiencing relief from them. Now, the problem was I had clomipramine, Ross. Clomipramine was like magic for me, but the dosage that I would have to take, I would be disabled. I wouldn't be able to work or stand up straight if I took the dosage that feels good. So it's a balancing act with the medications. Those medications are disabling for me. So the amount of clomipramine that I can take takes the edge off of those intrusive thoughts. So I can live a quality of life with clomipramine and about 3 other drugs that enables me to understand at a very high level what my brain is doing and manage it all day, but it's exhausting. And so I end up at this very high functioning level of, this is a compromised quality of life. I'm basically managing my obsessions all day and working full time and wanting to help other people. That's my life.
That's a good point that you bring up, because a lot of times I see it's not just being strictly treatment resistant, it's the amount that it would take. And with clomipramine, I'm not quite at that dosage yet, but there's always this escalation that's required to higher dose, and then once you've reached the max, you move on to a different drug, and then you rinse and repeat up until, I don't know, because I haven't gone through them all yet, but it can be daunting, certainly, but also, like you had mentioned, it's not a cure. It doesn't make them go away. It helps you push them to the back or express them with someone more easily, we could say. But they're still there, and it's still something that you have to manage. And It can take a toll on you. It's a certain level of stress that someone without OCD might, I say might, because there's other things that people can have, but they might not have that base level of stress in their lives.
Yeah, you know, it's Donna, you're talking about sort of harm OCD, and the interesting thing is that when someone is diagnosing and they understand what's going on with OCD, what they learn or what they know from their experience is that when someone has an OCD type of obsessive thought, it's something that they would never do. They talk about it, they think about it, they have these, obsessive thoughts about it, but they would never do it. And that's one of the things that causes them so much distress, because there's a clash between, I have this thought on one hand, but my values are such that I would never do what this thought is saying. So I end up with this clash between the two, which causes all this distress. But for someone who doesn't recognize it as OCD and isn't sure what's going on, you can imagine their fear, their concern. Oh my gosh, we don't want Donna to hurt herself. We don't want Donna to kill herself, without recognizing that Donna would never do that. But, they've got to diagnose what it is first. So that's always an interesting thing to see when when you get the proper diagnosis, then all these other things start to fall into place and they start to make sense. So, Donna, I'm curious, because I either missed it or I've never been clear. Have you ever tried ERP, or you've only tried the medication and the TMS?
I have only done medication, a ton of CBT, and ketamine, and TMS. And anything that I haven't done yet is just because it either hasn't been covered by insurance. If it hasn't been covered by insurance, then I haven't done it because I've been paying for other medical stuff. So the finance is a big issue. Finance is a big issue, and time is a big issue, because I was when Ross was talking about the medications, my biggest issue is definitely the side effect of sedation, because the medications sedate me. So, and I have a full-time job. So I basically run out of time. There's no time left in the week to go to more therapy. As a matter of fact, I just had to stop therapy with a new psychologist because he won't do therapy remotely. And I don't have an extra hour to get in my car and drive to his office. I just don't have that kind of time during the workday. So I can't see that doctor. Remote is much more efficient. So I'm somewhat interested in other therapy, but I really don't have the time and the money to do it. Whereas TMS, which is transcranial magnetic stimulation, is right around the corner from me at a hospital. It's covered by insurance, and the copay is very low. Mm-hmm. So, and it has no side effects. There are side effects, but the side effects are so much easier to manage for me, and just the compulsions and the obsessions, the disturbing thoughts have just been completely taken away. So I'm still obsessive, but about other things, but that's all nothing compared to the harm stuff.
Mm-hmm. So can you describe for our audience a little bit more, when you talk about the transcranial magnetic stimulation, can you answer two questions? One, can you describe physically what does it look like? What do they do? And then secondly, can you tell us, is that something that you do once? Is it something that you do every day? Tell us more about the actual treatment sessions.
So if somebody looks up transcranial magnetic stimulation, they should look up all the brain treatments around magnets. Just look up magnets. Look up magnets with whatever your diagnosis is. Magnets OCD, magnets depression, magnets addiction, whatever, because there's different types of magnets. I'm doing transcranial magnetic stimulation. And they put a coil goes over your head. And this is the part where I'm not a scientist. These coils send, I don't know, electricity to your neural pathways, and they create activity in the brain. On my website, dailyd.com, you can see a whole lot of information regarding this, all the scientific explanation. But it really activates activity in your brain.
It kind of looks like a hair dryer, right?
It's a helmet. Well, the first thing they do is they put a cap on your head, and the cap has all these lines that are marked with where straps go. And I have pictures of it. I'm not posting the pictures online. I've been embarrassed enough in my life. I don't need my TMS pictures posted online. I look like I've had ECT, and it looks worse than ECT. Let's just say that. I don't know if you've ever seen ECT or One Flies Over the Cuckoo's Nest, but been there, done that. So TMS, actually, if anybody wants to email, it's d@dailyd.com. Maybe I'll send you my TMS photo. It's disgusting and scary, but it's like a bathing cap that has lines marked where all the measurements go. Basically what happens is they figure out where your threshold motor is, and that's measured by your thumb. So on the first, I'm having trouble finding words. Having trouble finding words is related to the medication. Some of you probably already know this because of the medications you take. You probably have trouble finding words too. So my mouth wants to say episode, but that's not the word I'm looking for. When they do a treatment, when they do the first treatment, they stimulate the area of the brain up here, and it causes movement in the thumb. And they find the exact spot that takes the least amount of trigger to trigger the thumb. And when they find that exact spot, they mark it with these lines, and you get your own cap, and your cap has all your measurements on it. And then you go every day. They put on the cap, and then on top of the cap, they put on this like helmet that has the coils in it. And then something goes on top of that. It's like being in an astronaut. What's that thing called? A rocket. Like, it's very claustrophobic. If you're claustrophobic, if you don't like MRIs, it's not as bad as an MRI because it only goes over your head. But I know some people don't like it. So that's what it's like. It's like a hair dryer. It's like a hair dryer from the olden days when I was growing up. Yeah. It's like a hair dryer. So the hair dryer thing goes on your head, and then a fan gets turned on. And if anybody, I will tape one this week. I'll tape one next week, and I'll put it online for you guys to see. Oh my God, I can't believe I just promised that. This is going to be so embarrassing. And then they turn it on, and what happens is there's a tapping against your head for 60 seconds every 20 seconds. No, every 20 seconds, every 20 seconds for 20 minutes.
Oh.
Some people can't stand it. Some people, like me, would do anything to get rid of what's going on in there. You could chop off my arm. I don't care, honestly. So for me, like, you get used to it. Some people who are good at meditating, I think they just kind of become one with the tapping. You can do it yourself. You can tap against your head and you can feel, you can hear it on the inside. You just, you get used to it. So I go every day. It takes a half hour to get there. I'm there for 45, 50 minutes, and then a half hour to get home, go back to work.
Well, you had mentioned before that there were some slight side effects. Can you tell us what type of side effects have you experienced?
Sometimes there's a little headache, but not anything like a bad headache. It's not anything like a bad headache, just a slight headache, which is no worse than any kind of buzzy headache you would have if you had just changed your dosage on a medication. A buzzy headache, nothing bad.
I see.
And I do get tired by the 4th week. By the 4th week, I definitely feel like I need to take a nap in the afternoon. I have felt that every cycle I've done. I have felt that by the 4th week. I feel like I need to like lay down a little bit in the afternoon, but your head's getting banged on. So, I mean, that's fair.
Yeah.
It's not unreasonable.
So how many weeks is a cycle?
6 weeks.
6 weeks.
5 days, 6 weeks, 30 treatments. I think the key is whether you can fit it into your schedule. Can you fit it into your schedule? If it was far away, obviously that would be a bigger issue depending on what the person's work schedule was. But for me, it's right around the corner. So it's very doable, and insurance is covering it. So obviously that's the big question. But it's been, I mean, the fact that there's no significant side effects is unbelievable. And the difference it has made for me is unbelievable.
Yeah, it's great to hear, a positive success story, because the insurance part from the OCD coil side is new. The insurance is just starting to approve that. And the science is still new there too, because its use is new. But there are scientific studies that show positive results with OCD. And I'm curious to see over a couple of years what that looks like as we do more and more of it. I do want to open up the floor to some questions from the audience, because I'm sure they may have some questions. If you're an audience member and you do have a question, you can ask it in one of two ways. You can either go to the question box and type it in, and I will read it out, or you can request access to speak, and I have to click a button here to let you speak.
Did I answer Kat's question? What does it feel like? Does it feel good? I've heard from people who don't like it. They don't like the banging on the head. So I think it depends on if you're a sensory sensitive person. Everybody has different levels of sensitivity. So, I've heard, like, even in my family, people, in terms of like getting a mammogram, some people like it's the worst day of their life, and then other people are like it's no big deal. I think it just depends on the person and how sensitive they are about getting their head tapped. But if you can put, it's so much like, the guys won't know this at all. What do you guys have? A baseball helmet. A baseball helmet would be like a what's the one in the beauty salon?
The hair dryer?
The hair dryer. It's like a hair dryer. It's like a bathing cap, and then on top of that, a tight cap, and then a hair dryer. That's what it's like. Or a football helmet, and then tapping. That's what it's like.
Well, I was able to grant access to Kat for her camera and
Kat.
audio. So Do you have any follow-up questions to that, Kat?
No, I think she answered all of them. Thanks, Donna.
Sure, sure. I definitely recommend it. It's just the best thing of anything I've ever tried. And it was like a light switch. It was that kind of thing. It's like when you take a medication that really makes a difference for you, how all of a sudden you feel like a switch was flipped or a flip was switched, or however you say that.
Oh, I do have another question. You said you do it for 5 days a week for 6 weeks, 30 treatments. How long does it last? Do you have to go back and get some more?
That's to be determined. So that's to be determined. It lasted a while. I went ahead and I did more because we were trying to get authorization for the OCD coil, and it was just kind of a treatment call of, it was a good idea to do it, to kind of urge the health insurer, the insurance company, to approve the OCD coil, because they were not necessarily going to authorize it. It was an area that they had not previously authorized. So the Johns Hopkins wanted to kind of show that it was really necessary, and it was really necessary. So I went ahead and I had more. Could I have lasted longer? You know, I could have lasted longer, but I'm trying to stop going for long periods of time, being in an unbearable place. I think one of the problems that I've had with OCD is that I've gotten used to life being unbearable. And I think that's one of the problems with OCD. And I think that's where I would like to focus my advocacy. I think what TMS has shown me is what life is like when it's not unbearable. And I didn't realize that life doesn't have to be unbearable. When I was in my first round of TMS, and it was right around that third week or fourth week, and all of a sudden I started having some days where I just didn't have these recurrent intrusive thoughts of doing really, end of it kind of things. I just couldn't believe it. I just had never had that lifted. And now it started back in October. And now here we are in May. And I swear I've gone now for over a month. I'm making plans for my future. I thought I wouldn't be here today. I had no intentions of being here today. Like, the age that I am, I didn't think I'd be here. I mean, not with the shape that my brain was in. And it's just unbelievable. So I got to get the word out about that, because it's just unbelievable. So yeah, it's definitely worth trying. Nothing has ever given me that level of relief. When you get that level of relief, now what I want to say to people is, do everything you can to get your life less unbearable, because it's possible.
Mm-hmm.
Does that make sense? I think with OCD, I think what's amazing to me is what we get used to. Like, we get used to life being at such a high level of being unbearable, and we just live with it. Like, I can't, from October till now, I can't believe, and I keep journals like crazy. Like, I document like everything. I go back and I look at my journal. I can't believe how hard I was working. I can't believe how hard it was. And this is pure OCD stuff. This is not major depressive disorder stuff. This is not anxiety stuff. This is OCD stuff. I cannot believe I was working like 10 jobs a day to manage OCD. And I think that's the part that people don't get. I think they don't get like how hard you have to work to get through an OCD day. It's unbelievable. No wonder we're exhausted. And now TMS has given me a break from that. And like all of a sudden, it'll be like just like the middle of the day or something. And I'll think, oh my God, like I'm just free to have a thought.
That's great that you had such positive, response with it. I'm really curious to hear from Ross. You've heard how Donna described how her days were prior to finding this treatment. Do you find that your days are similar, or what do you experience, Ross?
Well, OCD can vary pretty wildly from person to person, so long as the obsessions remain intact. I have sort of the opposite, where it's not harm necessarily, although I have had incredibly violent intrusive thoughts. And then, like you had mentioned, they're not things I would actually do, but they can be quite disturbing. I have a few very vivid memories of being very creeped out by things that have popped into my head. It is exhausting. It's daunting. I find myself trying to search for the motivation or being able to push through it to get a job done at work or to start. I have things I'm trying to do outside of work. The very bad TikTok that I mentioned before, it's something where I want to start scripting out videos and having a more methodical approach to it. But even that, all of the intrusive thoughts about how bad that's going to go, how everything's going to fail, just pushing through all of that is incredibly exhausting. And I also have thalassemia, which is an anemic blood disorder. So I started off with chronic fatigue to begin with. So there are some days where pushing through is just not an option. I've gotten to the point where I don't necessarily lie in bed all day with a migraine and just getting absolutely nothing done. But there are days that are close. And the depression can definitely peek through. Like I said, that was partially accurate. That's there. So with everything that's been said, like I had mentioned, TMS is not something that has been brought up to me, but it's definitely very appealing based on that description. It's something I'll be looking into because I've had that thought. I've had that thought a lot where if I just didn't have to deal with this, even for a little bit, I could get so much more done. I was, I'm highly intelligent. I aced all of my exams in school, but I didn't do any of the homework. I barely got by because I knew the material, but I wasn't able to do the work. And that's, extrapolate from there. So being able to do the work and then think clearly for a little bit, that would certainly help.
Wow. Well, I have a question that I've been thinking about since Donna mentioned it, and I want to encourage anyone in the audience, if you have a question or anything you'd like to follow up with, please feel free to chime in, type it into the question box, or ask to get access, and we'll give you access. But while we do that, the one that I wanted to follow up with is Donna shared how recently she was changing doctors, but the fact that her doctor, the current one, didn't do teletherapy made it impossible for her to get there. And I'm wondering, Ross, from your experience, does that impact your personal decision about, who you might see or how your treatment goes?
It absolutely does. I haven't had that same misfortune in that department. I've gotten pretty lucky, I guess we'll say, with respect to them being able to handle remote work or being willing to. When I've had to change providers, it wasn't because of that. Recently, I had a change in physician, and I actually don't know why. I have a new physician now, but she does remote as well. I will actually take that back because the original doctor that gave me my diagnosis, he did not do remote work. or remote telehealth. So it became a challenge to see him, and that's why I eventually moved on from him. So there was that, and it is a problem that I hear a lot about. Like I mentioned, I've gone to NoCD or NOCD. They have remote therapy. It seems to be pretty good. I've taken a bit of a break, but it's not because of them. Like I mentioned, it's treatment resistant, it's exhausting, and sometimes I even need a break from therapy. But there's definitely options out there, but you do kind of have to pick up every rock to find the right opportunity.
Yeah. Yeah. One of the things that I've seen, especially, I think, so many things changed during the pandemic and post-pandemic. And as a practitioner, one of the things that I've personally experienced is the number of people who live in areas that are maybe outside of the city in a more remote area. They don't have the access to therapists who are specifically trained in OCD. And the fact that there's more remote therapy going on now, a lot of those people from even different parts of the world are able to get access to OCD specialists. And one of the areas that I've been working on personally a lot, which is sort of a personal project of mine, is, okay, great. We have things like this type of a video call that we can talk with patients and share certain things. But in order to make therapy, now I'm talking about exposure therapy, in order to make that really as effective as we can, I'm working on a project now. It's if you're interested in learning a little bit more about it, it's at rxxrt.com. It's prescription XRT, so rxxrt.com. And what it is I'm developing a platform for therapists to be able to work with clients and share with them 360-degree pictures and videos of situations that might trigger their distress. We have artificial intelligence included in that, so that if a therapist needs to find a particular image that's going to help them with therapy with a client, they literally just type in what they need, and within 30 seconds or less, they get exactly what they want. We're working towards adding augmented reality. Right now, I can do it, but it's not at the pace that we can set it up commercially yet. But basically, I can take a 3D picture of a snake and drop it on your desk in front of you using augmented reality, or any picture that we want. But we're working towards adding that. So the bit about teletherapy is just improving and improving day by day. And with all that's happening in the world now with artificial intelligence and similar technology, I expect over the next 1, 2, 3, 4 years, we're going to see tremendous advances. And that just brings more access to people that currently may not have access to OCD treatment. So
I have a question. Is
Sure.
it okay if I just interject? Okay.
Absolutely.
The RxXRT, is that being used just for exposure, like exposure to phobic things, or is there more to it than that?
Well, it's designed for exposure therapists, and exposure therapists do the OCD treatment. They do phobias. They do social anxiety. Any sort of therapy that uses exposure therapy would use this type of a site. So, for me, primarily it's OCD. So, I'll give you an example. Like, I had a client who had obsessive thoughts related to bats, for example. Well, number one, it was teletherapy, so there's no way for me to get a bat to her. But I mean, I could show her pictures online, yes, and those were effective. But imagine having a 3D picture of bats around you, and you're standing in the middle of it, and wherever you look, you're seeing 3D bats. The exposure is going to be much more impactful. So that's one example. But think about just the basic realities. Let's say you have a client who has contamination fears related to public restrooms. Well, whether that client comes into your office or whether that client is doing teletherapy at home, you can't easily just go visit public restrooms while you're doing therapy. But by using this type of technology, you can literally visit a lot of different public restrooms, both in 3D or 2D. So, there's so many places that right now the only thing that we can do in terms of exposure therapy is imaginal therapy, telling the client to imagine a certain situation. Now, that is effective in some cases, but then there's those cases that it just doesn't have the impact. So, that's sort of the purpose for this is for any sort of diagnosis where you would use exposure therapy as your treatment. So let me check in with the audience and see if there's any questions. I did actually see a comment earlier from someone about EMDR, and I wanted to comment on that briefly. So EMDR, it's also something that I'm trained in and that I use. And here's kind of the story of how all that fits together. EMDR is designed to treat trauma. And real basic, what it does is it's based upon what's called dual attention. And dual attention means that when we have a traumatic experience, that traumatic experience typically gets burned into our midbrain, our amygdala. That's the part of our brain that's the fight, flight, freeze part of our brain. And it can get stuck there, and it can continue to come back and sort of haunt us on a regular basis because it's just stuck there. And so that trauma has this continuous impact on us. Now, if someone happens to have OCD and they also have prior trauma that has not been processed, it can make it difficult to do the OCD work because it's getting interfered with by the trauma that has not been processed. So with EMDR, when I talk about dual attention, what it does is it basically opens a pathway between your midbrain and your frontal cortex. And in your frontal cortex, that's where you do all the higher level thought processing of things. So you're taking something that's kind of stuck in your midbrain and opening a pathway so that it can move to your frontal cortex and be processed. And it's really amazing. Patients that I've used this with have gone their whole life with some sort of traumatic thing that's never been dealt with. And we can do one session. And when I say one session, it's typically a 2-hour long session. But at the end of that, they come back the next week and they're like, yeah, I'm over it. It's no big deal anymore. And so I have many OCD patients who also had trauma, and we will do EMDR and clear out the trauma first, and then we move on to OCD. But EMDR, while there are some therapists who, in my opinion, incorrectly try to use it for OCD, it doesn't impact the things that OCD, is based upon. So, it's kind of like putting a bandage on your leg when your arm is bleeding. It just doesn't make sense to me. So EMDR is used for trauma. It's very effective for trauma. Typically not used for OCD. OCD is typically your exposure therapy. There's inference-based therapy, which focuses on helping you understand why you're dealing with the doubts and how they're impacting you. And then typically, if those have not worked, that's when you start moving into the medication and eventually the TMS, the transcranial magnetic stimulation, or other things. So that's traditionally how it's done, but we're hearing, differences. Everybody is different here. So let me see. It looks like there's a question. No other questions there. So, so let me ask a couple other things here, just for clarification. Ross, you mentioned that you have a TikTok account up. Do you want to share what that address is if people want to look at it?
Sure. I could definitely use feedback, right? Should I type it in? I mean, I can just say it right here. It's at R055LE, so Rossell. R055LE. And it's basically my experience, the things that I've done. Well, we're getting through them. Experience with weight loss and fitness, because that does have a huge impact on your mental health as well. And then more recently, trying to capitalize on some trends that did not go very well.
Great. Well, it's, any sort of education, I'm sure, is helpful and appreciated out there. And I wanted to also clarify, Donna, I know you mentioned your website, but could you actually spell it out for us just so we make sure that we have it exactly right?
I wrote it in the chat. It's dailyd.com, DAILYDEE.com.
Great. Yeah, I just didn't want people to not realize that it was DEE and think it was just the letter D and then not be able to find you. So, okay.
Now they'll only get confused because you explained how to be confused.
You make a good point. But you've written it in the chat. What's that, Ross?
It's professional help.
Well, so I want to check in with any of the members of the audience if there are any other questions or comments or clarification that anyone needs. I want to be sensitive to our time, and I know we have just about 2 or 3 minutes here before the end of our session. So if you do have a question or any clarification, please go ahead and either type it in or request access, and I'll open up your mic and your camera. And while you all work on that, I do want to take this opportunity to thank Ross and Donna and all of our members in the audience who joined us. I think right now, anything that any of us can do to get the word out and help people understand what OCD is and how it works and treatments, so that, it's not this scary unknown thing, and then hopefully get more people properly diagnosed up front without, having to go through misdiagnosis and struggling with it. That's something that we're trying to work through as well. So, your guests have taken time to share their personal lives here, and we really do appreciate that because it helps so many other people. And, that's what this is all about. So any final words from Ross? Let's start with you. Anything from you final?
Oh, I feel so honored. It was great being here. I hope to be able to contribute more to the community and perhaps here as well. Donna, I definitely would love to speak with you again. I'm sure, like you had mentioned, we could go on and on and on and on. And I don't know, maybe that'd be good for me. Maybe it wouldn't, but I'm willing to give it a shot. Just thanks for having me.
Thank you. What about you, Donna? Any final words for our audience?
Just keep figuring out there. My dog has final words for the audience. Just keep figuring out what's going on with yourself, and keep trying to put it into words that your healthcare provider can understand. To me, that's like the whole thing. I got an email from one of the OCD organizations that said, "Have you had unpleasant thoughts?" I'm like, that's not how I would describe them, but I think I know what you're getting at. Like, unpleasant thoughts. Okay, we'll use that language. So I think we need to work on the language around OCD so that people know, like, what's being discussed, unpleasant thoughts. I wouldn't know that they were talking about what's in my head if they said unpleasant thoughts.
I think
they're slightly worse. They're slightly worse than unpleasant.
Yes.
But we're getting there.
Well, thank you for that. And I just want to mention, so for anyone in the audience, if you yourself or if you know anyone who might have OCD or think they have OCD or not sure how to deal with it. We do have the free, no obligation, no cost support group at stopmyocd.com. A lot of education there, a lot of sharing amongst people who have OCD, as well as caregivers or loved ones of those with OCD. So it's really helpful. Another resource for you is the International OCD Foundation. They have a website at iocdf.org. And there's another organization, the Anxiety and Depression Association of America, ADAA.org, that also has a lot of information and practitioners there about OCD. So there's lots of resources. Just go to stopmyocd.com and you can find the resources, you can find videos, you can find a support group. I'm trying to make it a one-stop shop for everybody. And we really appreciate you taking the time to join us this evening. I appreciate our guests taking the time to share their stories with us. And if we have additional programs, we will put it out as many places as we can to keep you all aware and apprised. So thank you, everybody. And I wish you a wonderful evening and success in everything that you do.
Bye, everybody.